ये साइड में आ रहा है ना, हटा दो. हाँ ठीक, नहीं वो साइड में आ रहा था. So we will continue fourth lecture in the series of diabetes, and today I will be telling you about OHA, that is oral hypoglycemic agent. Now this is the most important part of diabetes management, because majority of your patient, bulk of your patient, they are going to be managed on oral hypoglycemic drugs. Last time we discussed about insulin, but only a minority will be managed on insulin, and many times you will require some expert for managing insulin care. Now let us see what could be done for oral hypoglycemic drug. Now as I already told you, the overall management depends on number one MNT, that is medical nutrition therapy or lifestyle modification, which remains throughout. Second is oral drugs, which we are going to discuss today, and third is insulin, which we have already discussed yesterday. And just to remind you, our targets remains fasting sugar to be managed within 80 to 130, post meal less than 180, HbA1c less than 7, and blood pressure, which is although not a part of diabetes management, but it remains an integral attachment to the diabetes, 140/80 and less than 140/80. Now coming to classification of oral hypoglycemic agents. Oral hypoglycemic agent, there is a long list of drugs to choose from, and that is why it becomes many times difficult to choose until unless you are fully aware about the type of drug you are going to use, the side effects of drug, the pharmacology of drug, pharmacodynamics of drug. Of course, in medicine class we are not going to discuss details of drugs. I understand that your entire pharmacology and pharmacodynamics has been taught to you in pharmacology, but even then we will try to give some important clinical catch points during our discussion, so that you can pick and choose about the oral hypoglycemic drugs. Now just to classify the drugs, it is just a revision. You must be knowing bigonides are the most important drug. There was a time when bigonides, metformin, fenformin, they were literally thrown out of the window in overall 40-50 years of history of diabetes. When I was a postgraduate and a junior consultant at that time, metformin and fenformin, they were for a time being thrown out of the window, they were not used, and it is a no drug kind of drug. Subsequently, it has gained its place, and not only gained its place, but it has become number one drug now. And if you see the most recent ADA recommendation, American Diabetic Association recommendation, which are followed all over the globe, the first drug to start with in any given situation in type 2 diabetes remains metformin. So this is a very important drug, very cheap drug, easily available drug, could be used without much of effects, without much of side effects rather, and this should be integral part of management in literally every patient with type 2 diabetes. You will understand in coming slides. Second important class of drug is known as insulin secretory GOX. These are the drugs which increase the insulin secretion from the pancreas. So these are very effective drug to be yes, please come. These are very effective drug, but they have got their side effects as well, and they are to be used with caution. This is glimepiride, which is the most important drug these days. Other drugs are glipizide and glibenclamide, which was a very important drug in earlier days, but now it is not that commonly used. Then yet another class of drug known as thiazolidinediones. In this, two important molecules come, that is rosiglitazone and pioglitazone. Pioglitazone is more commonly used, rather roxy. So metformin, glimepiride, pioglitazone, these are the representative drug of these initial three classes. Then comes DPP4 inhibitor drug, which are commonly known as gliptins. Gliptin again is a very common drug, which could be combined with metformin, could be combined with sulfonylurea, and it is a very effective drug. There are many drugs, many molecules in this. I have just mentioned couple of them. I do not want to confuse you. So there is a linagliptin, sitagliptin and vildagliptin. All of them, they are equally effective with dose manipulation, and everybody has got its own dosing schedule. Then yet another class of drug is that is known as alpha glucosidase inhibitors. Now these are altogether different class of drugs, because their mechanism of action is altogether different, and this includes voglibose and acarbose. Then there comes a relatively newer drug which has been added just couple of years or rather a decade or so earlier, and it has found its place in use with a big bang, and this is sodium glucose cotransporter 2 or known as SGLT2 inhibitors. So, this group of drug to begin with was a very controversial drug, because once you will know the mechanism of action, practically this is increasing glycosuria, but somehow the mechanism is different, and ultimately this is a very effective drug, because this not only causes improvement in HbA1c and overall control of diabetes, but it takes care of many of the comorbid situation with diabetes, that is obesity, hypertension and so on. We will discuss something about when its number comes. And then there is a class known as non-insulin secretagogues. These are the drugs which are not insulin, but they have got a property of secretagogues, means they can increase insulin secretion. These are netiglinide, ripaglinide and mitiglinide. These are not very commonly used, but just for the sake of completion you have to understand. And then there is again a newer group of drug, that is GLP-1 receptor agonist, and in this group comes liraglutide, exenatide, dulaglutide and most recently semaglutide, which is an oral drug of this class. Otherwise all of them, they are injectable, could be given once a day, weekly and so on. They are very effective drug, but relatively costlier drug. So, I will go one by one. Now, before we go for detailing of these drugs within whatever time permits, let me tell you some common approaches and some common hints which are of clinical importance regarding OHs. Number one is insulin secretagogues, biagonides, GLP-1 receptor agonists and thiazolidinediones. They are the major drugs. In a way, they improve glycemic control to a similar degree, that is 1 to 2% reduction in HbA1c. Now, how does this help? Because if your patient's HbA1c is 8, 8.5, then monotherapy is going to work. So, either use of biagonide or maybe insulin secretagogue, just like sulfonylurea, may bring down his HbA1c to the desirable level of less than 7. But suppose it is 9 or 10 to begin with, then from day one he is a candidate for polytherapy, because as I told you right now, these drugs on their own, they are capable of reducing HbA1c to the tune of only 1 to 2%. 2% is the upper limit. Generally you achieve target of 1%, 1.5, something like that. So, if HbA1c was 8.5, then probably you can expect it will come down by 1.5, that means it will be around 7. So, good control could be achieved, but suppose it is 10 to begin with, then you should not expect that this will become 7, because it can never achieve reduction of 3% of HbA1c. Okay. So, they are more effective than alpha glucosidase inhibitors, DPP4 inhibitors and SGLT2 inhibitors. So, in a way there is a distinction between initial 4 classes which I told you right now, that is insulin secretagogues, means sulfonylurea, biagonides, GLP-1 receptor agonists and thiazolidinediones, which are relatively more effective in comparison to other drugs just like alpha glucosidase inhibitors, DPP4 inhibitors and SGLT2 inhibitors. With similar degree of glycemic improvement, no clinical advantage to one class of drug has been demonstrated. So, overall if you see by and large, if you achieve a reduction of 1 or 1.5 or 2 HbA1c with any molecule, the effect are nearly similar. There is not much of a difference, although minor differences will always be there. Someone will be more effective, someone may be more appropriate for a given situation than the other. That is always there, because every drug has got its own relative contraindication, indications and as well as side effects profile. Insulin secretagogue, just like GLP-1 receptor agonists, DPP4 inhibitors and alpha glucoside inhibitors and SGLT2 inhibitors begin to lower the plasma glucose immediately. Now, again this is a difference between this class of drugs which I mentioned right now, secretagogues, GLP-1 receptor agonists, DPP4 inhibitors and glucosidase inhibitors. They are having immediate effect. That means you use the drug today and tomorrow onward the reduction of sugar will start taking place. But there are relatively slower acting drugs just like biagonides, thiazolidinediones, their effect may be delayed by weeks. So, maximum effect may be achieved after maybe a week or so. So, you should not expect that you have given metformin yesterday and just for a day or two and blood sugar will start falling. it is not true, it will take some time. Bigonides, alpha glucosidase inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors and thiazolidinediones and SGLT2 inhibitors do not directly cause hypoglycemia. Now, you know, one of the most important consideration whenever you are using insulin or oral hypoglycemic drugs remains hypoglycemia, which may be sometimes life threatening, and especially in the presence of autonomic neuropathy, which is generally an integral part of diabetes in long run. Many symptoms of hypoglycemia which are generally seen very commonly and which makes person aware that his blood sugar is going low may be missing in diabetic patient. That means, they may not develop tachycardia, sweating and other things which hypoglycemia causes, tremors in a non-diabetic person. So, meaning thereby that their hypoglycemia may remain undetected to the tune of going in the range where the sensorium may be altered, and that is why quite often you will see in the casualty that a diabetic patient is being wheeled in on a stretcher and his blood sugar is 40, he comes and a resident on duty injects 50% glucose and he just gets up and starts running, and this is one of the miraculous situation in overall medicine, where you can treat within minutes. Person who is lying unconscious in front of you may start running after 50% dextrose has been given, because he was having hypoglycemia, right, maybe 40, 30 blood sugar, and this is a very, very common situation, and that is why we are more willing to use those drugs which are relatively less hypoglycemic concern. Just like sulfonylurea is a drug which may cause significant hypoglycemia, it is a very effective drug, but in elderly 70 plus individuals, if you are using sulfonylurea, you may face a very significant hypoglycemia sometime or the other, and usually the precipitating event remains that person was not feeling well, he has not eaten, but he has eaten his drug as per schedule, सुबह से उठ के नाश्ता किया नहीं, ठीक नहीं लग रहा है, लंच भी स्किप कर दी और गोली खा ली. So, it is going to crash the blood sugar, because blood, whenever there is a prerequisite with the oral hypoglycemic agent or with insulin also, that whenever you take these drugs, it is to be followed by the meal, so that when the excursion takes place, blood glucose starts rising, the drug is there to check the blood glucose. If the person is not eating, he has taken the drug, it is an uninhibited response and his blood sugar is going to crash. This is the usual situation which is faced by many physicians, and you will also face whenever you are practicing your medicine. Durability of glycemic control is slightly less for glyburide compared to metformin or rosiglitazone. Now, coming to mechanism of action of OHAs, again I will not go in details, because as I told you, I am not taking a pharmacology class, I am teaching you medicine, but still some facets of understanding I will keep on touching. So, various drugs, they have got different mechanism of action, but overall there are 3 or 4 important mechanisms by which oral hypoglycemic they work. One is increasing insulin secretion, that means they stimulate the pancreas and the beta cell for their functioning, and whatever function is there, whatever beta cell reserve is there, depending on their number and their reserve and the functional capacity, insulin secretion will increase, and these drugs are known as secretagogues, means they increase. It is just like whipping your horse. When you must have seen a bullock cart or a horse cart, and the person sitting over there, whenever he wants horse should run little faster, he just gives a small whip and he starts walking faster. It is a similar kind of situation. These secretagogues, they stimulate the pancreatic beta cell, so they start secreting more and more insulin, but again there is a limit to it, because they are already exhausted cells, they are already non-functioning cells, they are already poorly functioning cells, and if you keep on whipping them, maybe sometimes they will perish early, apoptosis will take place, and that is why secondary failure sets in after a couple of years, generally 5 years for sulfonylurea, maybe maximum 10 years, when they will not be effective anymore, because now their whipping is not going to cause any difference to the pancreatic beta cell, they will no more induce more insulin secretion, right. So, secretagogues, they work by this increased insulin secretion. Then there is reduced glucose production, which is generally done by bigonides, increased insulin sensitivity, which is a classical feature of thiazolidinediones, that is pioglitazone, which is the insulin sensitizer, which increases in insulin sensitivity, and that is why usually this is a supplementary drug with other drugs which are the main stem drugs, maybe sulfonylurea or maybe sometimes even insulin. Enhance GLP-1 action and promote urinary excretion of glucose, and this is unique for SGLT2 inhibitor, which I told you this is a newer class of drug which has been added just a decade or more, you can say in early 2010 onward this drug has come in the market, and within very short period this has gained a tremendous popularity in spite of its mechanism of action being diagonally opposite which you desire to be. You desire that glycosuria should reduce, but this is a drug which is increasing glycosuria. If the glucose excretion was 1% or maybe 1 plus in the urine, it will cause 2 plus glucose in the urine, and I will let you know how it does when it comes to SGLT2 inhibitors. Now coming to individual drugs, I will be fast in between somewhere because I have to cover long way within this short time of period, the entire oral hypoglycemic range of drugs. So I will try to concentrate more on those drugs which are more commonly used, which are you are going to use in day to day practice, and you should know more about those drugs. Then there are certain drugs which are not that commonly used. So even if you do not know much about those drugs, it will not matter. So bigonide, as I told you, is number 1 drug. Practically every type 2 diabetic patient, if somebody is there in your family, you will find his prescription must be having metformin, either alone, solo, or in combination with sulfonylurea, with gliptin, with SGLT2 inhibitors, and so on and so on. This is a drug which could be combined with any other group of drugs and could be used safely. Metformin is the main representative of this class of agent. Bigonides, there used to be 2 important molecules, metformin and fenformin, but fenformin, because it causes significant lactic acidosis, it has been withdrawn from the market and this is no more available. And this was the reason that being same class drug, there was a period when metformin were also thought to be that it is the sister of fenformin, so it should not be used, but subsequently it was found that although it belongs to the same class, but lactic acidosis is not that commonly seen, and it is seen in a very heavy dose of metformin, and that is why it has been used again, and this has slowly climbed the ladders and it has reached number 1 drug, and nowadays it is undisputed king of diabetes management as far as the OHA is concerned. Mechanism of action is it reduces hepatic glucose production by antagonizing glucagon's ability to generate cyclic AMP in the hepatocytes. It improves peripheral glucose utilization. So, it has got multiple actions for hyperglycemic control, liver as well as peripheral action, and metformin activates AMP dependent protein kinase and enters cells through organic cation transporter. So, it has got multiple action. Beside that, metformin is a drug which has got pleomorphic effects. Now, pleomorphic, you must be knowing by the definition, is a situation or a term when a one thing is doing many things simultaneously, that is the pleomorphism or pleomorphic effect of the drug. So, metformin not only controls hyperglycemia, it is lipid friendly, it is going to control lipids little, it is causing some reduction in the appetite. So, it is friendly, it can reduce weight in the obese person, then it is having endothelial protective effect, it is having many other pleomorphic effects which are favorable in diabetes complication prevention in long run. So, metformin is a very effective drug, very well tolerated drug. There may be some minor side effects just like oral intolerance, sometimes nausea, sometimes little diarrhea, but this is very well acquainted with in a longer run. So, when the patient starts taking drug, maybe to begin with he will have little issues, but if he continues to take, these will be settling within no time. Metformin reduces fasting plasma glucose and insulin levels, improves the lipid profile and promotes modest weight loss. So, it is useful in these areas also which are equally important in type 2 diabetes. Insulin should be used in place of metformin in patients who are nil orally, hospitalized patient, and those receiving radiographic contrast media. So, there are certain situations where a short time insulin use in presence of metformin or withholding metformin and giving insulin for a day or so could be done. In these situations, in hospitalized patient is nil orally for some reason or receiving some contrast study, then a short insulin could be used. metformin, because of its relatively slow onset of action and GI symptoms with higher doses, initial dose should be low. Now again you have to learn to live with different drugs. Different drugs, they have got their own profile, they have got their own dynamics, as I told you. So understanding pharmacology of each and every molecule is extremely important. Leave aside anti-diabetic drug, any other drug, any class of drug. So you have to have profound understanding of the pharmacology of that molecule, then only you can use it judiciously. So regarding metformin, this is a drug which is used with a smaller dose, usually 500 once a day or 500 twice a day, and then increase slowly to 750 twice a day, then maybe 1 gram sustained release twice a day, up to maximum dose of 2 to 3 gram per day. And for this purpose, SMBG, that is self monitoring of blood glucose, is generally done, and usually after every 1 to 2 week increment is done. It is not that कि आज आपने 500 मिलीग्राम दिया, 2 दिन बाद फास्टिंग पीपी लिया, अभी तो हाई चल रहा है, उसको बढ़ा के 1 ग्राम कर दिया. It is not done like that. You have to wait for a week or 10 days or maybe 2 weeks to be on safer side, because as I told you in my initial few slides that there are certain drugs which starts acting immediately, just like sulfonylurea, you give in the morning, effect will come in the evening. Certain drugs, they take time for maximization of the effect. Metformin is one of them. Metformin is effective as monotherapy and can be used in combination with other oral agents or even with insulin. So metformin is a drug which you will find, but for type 1 diabetes, practically every patient of type 2 diabetes, if he is being used by a good physician, he is being treated by a good physician or an endocrinologist, and he must be having metformin as an integral part. Why I am saying this? Because there are many prescriptions nowadays which are driven by MRs, that is medical representative, who comes to you, and because of your vested interest and his vested interest, you start writing new molecule without knowing what you are writing. For example, one of the classical example of this is semaglutide. When we sit in the outdoor, every day we find patients coming with 8 HbA1c, he is receiving semaglutide. Semaglutide is a drug which costs 50 to 100 rupees per day. It is a drug full of side effects. It is a very effective drug, but it is a drug which is to be given in certain situation. But because of your personal reason, because MR is pushing you, sir ye likhna, sir ye likhna, sir ye likhna, and because you are being pampered by him, so you are inclined to write. But as I told you, any good physician or any good endocrinologist will prefer first molecule as metformin only. Maybe he will use semaglutide also, but maybe sometime when it is required. Long term use is associated with reduced micro and probably macrovascular complications. So this is a very effective drug in taking care of complications. Rarely it can cause lactic acidosis, because this is a group side effect, as I told you. Fenformin was withdrawn from the market only because of this lactic acidosis. So it can rarely cause, and one of the important side effect is that decreases B12 absorption by 30%. So whenever you are using metformin, a chance that person may develop B12 deficiency, and that is why he should be having some supplementation or some sources of B12 as regular along with metformin, because it is going to hamper absorption of B12. Metformin should not be used in patients with moderate renal insufficiency, GFR less than 45 ml per minute, any form of acidosis, unstable congestive heart failure, liver diseases or severe hypoxemia. So whenever a good physician starts writing metformin, he is keeping these in mind, that he is not having acidosis or he is not having CHF, heart failure, because these are relative contraindication, you have to use with caution. Second important drug is, most important drug after metformin is sulfonylurea group of drug. These are secretagogues, that means they are the drug which are going to increase insulin secretion, and this is the most effective drug out of the entire oral hypoglycemic paraphernalia, because this can reduce maybe 2+% of HbA1c. As I told you, up to 1 to 2%, but usually above limit of 2% could be achieved by sulfonylurea alone. So if you are using even 1 milligram of glimepiride in a new virgin case of type 2 diabetes, maybe his HbA1c will fall by 2 with sulfonylurea. These drugs are most effective in individuals with type 2 diabetes of relatively recent onset. As I told you, less than 5 years onset, because he is the one who is having plenty of beta cell is still functioning, and that is why secretagogues are going to work. Suppose he is diabetic for 15 years, he says कि हाँ साहब डॉक्टर साहब 10 साल से गोली खा रहा हूँ, गोलियों के नाम बताए उसने आपको, some medicine is sulfonylurea and he says कि आप कंट्रोल नहीं आता है, then you should not expect much from sulfonylurea because he is already going towards secondary failure of sulfonylurea, where sulfonylurea will no more be effective, or if they will be effective, it will be effective with lesser and lesser potency, and that is why you have to supplement some other molecule just like GLP-1 or SGLT2 inhibitor in that individual along with sulfonylurea. You can bring down the dose of sulfonylurea and increase or add some other molecules. So, you have to learn how to tackle and how to keep on manipulating oral hypoglycemic drug, because you have got a long plethora of long list of oral hypoglycemic drugs, but that you will be able to do only when you know each and every molecule, their side effects, their pharmacodynamics, their effects, their limitations and everything, right. And that is what I have been emphasizing, that you should be knowing full pharmacodynamics and pharmacology of these molecules, then only you will be in a position to use them judiciously. Now, there are two generations of sulfonylurea. First generation are no more used. This used to be chlorpropamide, tolbutamide. I have used plenty of this molecule in my 80s and 90s and even early 2000, but these molecules have been no more, they are no more used because you have got a better second generation sulfonylureas available. They have more rapid action and better coverage of PP sugar rise, but the shorter half life of some agents may require more than once a day dosing, and these includes glimepiride, glycoside and glipizide. So, nowadays out of sulfonylurea, usually these three molecules are the one which are preferred one by the other. One physician may be using more glycoside, may be using more glipizide. As far as I am concerned, I use only one molecule out of this, that is glimepiride, which is the most effective drug, most easily available, just 1 milligram dose is sufficient, but you may have your own choice because of various reasons. Sulfonylurea should be initiated at low doses and increase at 1 to 2 weeks interval based on SMPG. Again, this is a drug which should be slowly upgraded. In general, sulfonylurea increase insulin acutely and should be taken shortly before a meal. So, this is very important that you have to emphasize this to the time and again to the patient कि गोली खाई है तो खाना खाना ही पड़ेगा उसको, मतलब गोली खा लिया खाना भूल गए, he is a busy executive, he got entangled in some meeting, he has taken full dose of sulfonylurea and then he got himself busy with some meeting for 2 hours, he has not taken anything. You should not be surprised that he will be found unconscious in his room because he has gone into hypoglycemia. So, this is extremely important that whenever you are taking drug, it has to be followed by meal. Long term use is associated with reduced micro and macrovascular complications. Glimepiride and glipizide can be given in a single daily dose and are preferred over glyburide, which is a name for glibenclamide also. This is a very long acting drug, especially in the elderly. So, glibenclamide is no more used nowadays because you have got better molecules available, but this is a very effective drug, mind it. I have used this drug for 2 decades at least, and even 1 milligram of glimepiride used to keep patients 24 hours free of diabetes, means reasonably controlled. But again, hypoglycemia is an important concern. Weight gain is a side effect of sulfonylurea therapy, results from increased insulin levels and improvement in the glycemic control. So, one has to be careful because type 2 diabetics, they are usually overweight, and if person is really very much overweight, you are concerned with his weight, you want to reduce the weight as well, then probably you can have some other drug rather than sulfonylurea as the initial therapy, maybe metformin with gliptin, metformin with SGLT2 inhibitors rather than sulfonylurea, because with sulfonylurea weight gain होगा ही, 1-2 किलो 4 किलो वजन बढ़ जाए, you should not be surprised because this is what the sulfonylurea's main side effect is, it is going to increase weight. Glipizide is again 2.5 milligram to 10 milligram tablet taken as a single dose or in 2 divided doses 30 minutes before breakfast. Glimepiride is available as 1 milligram, 2 milligram or 4 milligram tablets taken once a day with breakfast or twice a day with meals. So, could be taken 1 milligram twice daily also, but generally single dose is good enough. Longer acting drugs can cause hypoglycemia, as I have been emphasizing time and again, especially in the elderly individual. So, their use is contraindicated. So, you should not try to use any long acting sulfonylurea in 70 plus individual, because you are going to face hypoglycemia sometime or the other and it could be really troublesome. Significant drug interaction with alcohol and medications such as warfarin, aspirin, ketoconazole and alpha glucoside inhibitors and fluconazole is known with sulfonylurea. As I told you, you have to be fully aware about the pharmacology, pharmacodynamics, drug interaction, toxicity, and this is a full subject. So, I am not going anywhere near to it, but until unless you know, you will not be able to manipulate the treatment, because if the patient is receiving warfarin, he is receiving some antifungal drug, then you have to understand that his doses may be slightly different. And then coming to non-insulin secretagogues, I have already told you that this group of drug is not used. So, just for the namesake I made the slide. Ripaglinide, netiglinide, mitiglinide are the drugs. I have never used them, are not sulfonylurea, but they interact with the ATP sensitive potassium channel and increase the insulin secretion. So, these are known as non-insulin secretagogues. Because of their short life, these agents are given with each meal or immediately before to reduce blood related glucose excursion. So, this is preferred by those executives which have got erratic schedule of their eating, because they are busy with somewhere, they are meeting again 4 बजे, एक दिन 4 बजे खाना खाया, दूसरे दिन 12 बजे कुछ ले लिया, तीसरे दिन 3 बजे खाएंगे. So, these are the drugs which are meant for those class of person. They may induce hypoglycemia, they are contraindicated in chronic renal and liver diseases, but again as I told you, even if you do not know about these drugs, it is hardly going to matter, because you are not going to use them. Again, this is a group of drug, GLP-1 receptor signaling antagonists. They are very effective drug, very useful drug. They are next to insulin, but as I told you, there are certain classes of drug which we prefer and certain classes of drug which we do not prefer. This is one of the class of drug which is very effective, but we do not prefer, because अगर use ही करना है तो insulin ही क्यों नहीं use कर लें. So, this is practically equivalent to using insulin, but this is a very costly drug, right. Insulin is nowadays relatively very cheap, and that is why this could be short acting, this could be long acting to the tune that once a week may be used, and this may be very effective in controlling. Short acting are exenatide and lixisenatide, and long acting are liraglutide, albiglutide and dulaglutide, right. But as I told you, generally we do not use much of these drugs. So, even if you do not know these molecules, it is okay. GLP-1 receptor agonists, they are known as incretin, they are parenteral drugs. They increase glucose stimulated insulin secretion, suppresses glucagon and slow gastric emptying, do not cause hypoglycemia, do not promote weight gain. In fact, most patients experience modest weight loss. So, this is a very good drug. Insulin versus this drug, it overweighs insulin, but for price, because insulin causes weight gain, this causes weight loss. So, those persons who are obese and they can, affordability is not an issue, they say कि नहीं डॉक्टर साहब कोई दिक्कत नहीं है, 100 रुपये रोज का भी ट्रीटमेंट होगा तो चलेगा, then it is one of the preferred drug in these kind of individuals. Even long acting molecules are available which could be used up to a week, once a week or even twice a week. GLP-1 receptor agonists, they are available in twice daily doses, weekly injectable formulation, could be used as combination therapy with metformin, sulfonylurea and thiazolidine. So, they could be combined with any. The major side effects are nausea, vomiting, diarrhea. Now, these gut side effects are there because they are GLP-1 receptor agonists. They cause gastric emptying issues, they may influence the absorption of other drugs. When GLP-1 receptor agonists enhance beta cell survival or promote beta cell proliferation in the human is not known, because there is one theory, because it is not acting through beta cell, it is acting through GLP-1 receptor side, that is why beta cell preservation is there, but this has not been, this is just a hypothesis, it has not been proved. Now, this is about semaglutide. Now, this is a drug which has opened a new chapter in diabetes management in a way that you will be surprised that this is a protein molecule, this is amino acid group of molecule, but for the first time some mechanism has been evolved and developed where it is not digested inside the abdomen, and if the same could be applied to the insulin, because insulin is also the only limitation why insulin is given injectable, because it is a amino acid. So, if you give orally, immediately it will be digested, broken down, and it will be no more in the form of insulin molecule, and that is why it will not be effective. Otherwise, if you are able to make insulin by oral route, this will be the most physiological, most effective way of treating diabetes, because you want insulin delivery to be done in the portal circulation. Right now what you are doing, we are delivering insulin to systemic circulation. So, this is a basic defect between insulin, normal physiological production and use of insulin, and our use of insulin, which is the most effective number one drug for diabetes management is insulin, no doubt about that, right. So, this was for the first time some mechanism has been developed, some coatings and some other things which I will not go in details, by which this is the gastric digestion is bypassed and this is reaches jejunum and this is absorbed there. But this is at a cost of a very heavy dose. That means, if the dose required is in micrograms, you are using 3 milligram, 7 milligram or 14 milligram dose, because nearly 80 to 90% of the drug is wasted in this process of reaching into the jejunum. But even then, this is a very effective molecule, although it is a costly molecule, semaglutide. So, nowadays oral GLP-1 receptor agonist is available in the form of semaglutide, and being a newer drug and a costlier drug, it is that every company is behind use of semaglutide कि सर इसी को use करिए, इसी को use करिए, इसी को use करिए, and that is what I was referring to. Whenever you are sitting in OPD, I am sitting in OPD, I find many prescriptions coming with semaglutide where indication is not there. The patient would have done very well with metformin or just 1 milligram sulfonylurea, but still he has been preferred to use semaglutide, and his pocket is losing maybe couple of thousand per day for no use, and he is having side effects of oral nature. He complains of heartburn, nausea, vomiting, stomach pain, diarrhea, headache, dizziness, hypoglycemia, all of them, but because he has been prescribed by semaglutide by someone who thinks that this is the only drug for diabetes, then he is using. So, many times we have to change and then we have to switch over to some other simpler drugs. Then there is one more group of drug that is known as gliptins. These are DPP4 inhibitor drugs and these are known as gliptins. This includes linagliptin, saxagliptin, sitagliptin, vildagliptin. There are many more molecules, because once a molecule comes, then molecular tempering and shifting one atom from here to there starts, and then many molecules come into the picture. So, DPP4 inhibitors, they inhibit degradation of the native GLP-1, thus enhance endogenous GLP-1 action. It is widely expressed on the surface of endothelial cells and some lymphocytes. DPP4 inhibitors are used either alone or in combination with the other OHs. They promote insulin secretion in the absence of hypoglycemia and weight gain. So, they are relatively good drug. Again, I will not go in little details. Linagliptin is used as 5 milligram daily, vildagliptin used as 50 milligram once or twice daily, sitagliptin is used as 25 to 50 milligram or 100 milligram once daily. So, again you have to become friendly with any of these gliptin. You should know each and every aspect of the pharmacodynamics of that molecule, then only you should start using it, because as I told you, right now you have got at least 50 oral anti-diabetic molecules available in your armamentarium, because every group has got 5-6 molecules, 5-6 molecules. Even DPP4 inhibitors, I am telling you only 3 or 4 molecules. There are 4 plus more which are available, and every 6 months or 1 year one new molecule keeps on coming. They can cause acute pancreatitis. This is one of the big limitation. Coming to alpha glucosidase inhibitor, this is a altogether different class of drug. They reduce postprandial hyperglycemia by delaying glucose absorption. So, then they do not allow glucose absorption, they delay the glucose absorption in the intestine, small intestine. So, that is how they work, that is acarbose and voglibose. They do not affect glucose utilization or insulin secretion. So, they have got nothing to do with the insulin secretion, nothing to do with the glucose utilization, the glucose absorption is delayed. Okay. So, these drugs taken just before each meal, they cause glucose absorption delaying by inhibiting the enzyme that cleaves oligosaccharides into simple sugars in the intestinal lumen. And the action is because ultimately the glucose molecule is formed by cleavage of polysaccharides, that is maybe sucrose or other bigger molecule, ultimately it cleaves into 2 and then the glucose or fructose is formed. So, this inhibits that enzyme, and that is how this delayed formation of glucose molecule. Therapy should be initiated at low dose, and examples are voglibose and acarbose. They can cause diarrhea, flatulence, abdominal distension, because as I told you, it is delaying the absorption, and oligosaccharides they remain in the bowel for a longer period. If hypoglycemia from other diabetes treatment occurs while taking these agents, consume glucose, because the degradation and absorption of the complex carbohydrates will be retarded. So, generally on an average what you do when hypoglycemia is there with any oral hypoglycemic, but for acarbose, that you give sugar, जो आपका घर में चीनी रहती है, but that is not glucose, that is dextrose, that is a polysaccharide or disaccharide, sorry. So if you give that, again it will not be degraded into glucose, and so hypoglycemia will not be corrected, because sugar is not used in the body as a molecule, it is only the glucose which is used at the cellular level, and that is why this is a precaution, that if glucosidase inhibitor is the one which has caused hypoglycemia, then glucose or the oral glucose will be only effective. If you try to give 2 spoonful of sugar dissolved in a glass of water, शरबत बना के पिला देंगे तो वो काम नहीं करेगा, क्योंकि उससे शुगर बनेगी ही नहीं आगे जाके, मे बी फॉर नेक्स्ट हाफ एन आवर it will be slowly decomposed, and by that time hypoglycemia will start crashing. Then thiazolidinedione, these are known as insulin sensitizers, they work on PPAR gamma receptor. PPAR gamma is found at highest level in adipocytes, circulating insulin level decrease with the use of thiazolidinediones, indicating a reduction in the insulin secretion. So, the 2 molecules are there, roxyglutathione is not that commonly used, pioglutazone is the molecule which is generally used. It is used in 15 milligram, 30 milligram or 45 milligram tablets daily doses. Many of these, just like troglutazone was withdrawn from the US market because of the hepatotoxicity. There were 3 molecules earlier, troglutazone, pioglutazone and thiaglutazone, but nowadays only 1 or 2 molecules are available. So, I will not again go in details. Coming to SGLT2 inhibitor, as I was referring to you, because I am running short of time, these agents lower the blood glucose by selectively inhibiting the co-transporter which is expressed at exclusively in PCT, the proximal convoluted tubule. You must be knowing from your physiological understanding that every glucose molecule is filtered in the kidney and it is reabsorbed again by PCT, because glucose is a small molecule. So, it is filtered and reabsorbed, filtered and reabsorbed, that is how the glucose glycosuria does not take place, but this is the drug which is going to inhibit this process, and so glycosuria will take place. That means more and more glucose will be thrown out of the urine. The glucose lowering effect is insulin independent. So, if there was blood glucose of 300 or 250 and you start throwing more glucose in the urine, automatically the blood circulating blood glucose level will come down. So, that is how it does work. There are many molecules available, empagliflozin, canagliflozin, they reduce CVD event and all cause CV mortality in patients with type 2 diabetes and established CVD. Why this has become so popular? Because this is the only drug which has been found to reduce CV mortality, cardiovascular mortality, and diabetes, the biggest problem is CV mortality in diabetes, because it is a macrovascular complication. So, somehow this molecule is having a very favorable effect for CV mortality, to the tune that this has been recently used in non-diabetic cardiovascular disease situation, where the person is non-diabetic, even then he is having just heart failure, maybe he is hypertensive, heart failure, and you will find his prescription contains SGLT2 inhibitors, right. So, this is a drug which has become so popular, because many long term RCTs, they have found favorable effect on cardiovascular mortality. They impair proximal reabsorption of the sodium, they are usually associated with a diuretic effect and 3 to 6 millimeter fall in blood pressure. And why they do this favorable benefit is because they reduce blood pressure, they reduce sodium load in the body, and they reduce weight as well. And so, indirectly it takes care of many CV risk which is associated with diabetes and even in the non-diabetic. They also reduce the risk for nephropathy and rate of hospitalization of congestive heart failure. So, this is a established fact that this drug has got many favorable effect, and that is why SGLT2 inhibitor has become popular molecule in diabetes as well as in non-diabetic situation. In heart failure, this is being used increasingly in heart failure. Due to the increased urinary glucose, urinary and genital mycotic infections are common in both men as well as women. So, this can cause fungal infections in genitourinary tract, and this is big limitation of this drug. And these are the dosing schedule which you can skip. Now, coming to the last portion of my slide, now this is how to pick and choose. If your blood sugar is less than 200, HbA1c is 8, then probably you will start with medical nutrition therapy. Initiate oral drug if target fasting capillary blood glucose is not achieved by MNT, then probably a small dose of metformin may be started. If it is 200 to 250 blood glucose and 8 to 9 HbA1c, then single oral drug with MNT will be a preferred scenario, and here the single first drug will be probably metformin. So, metformin, unless contraindicated, check blood glucose after 1 to 2 weeks. If target achieved, escalate dose to maximum, move to next stage if target not achieved. And what is this next stage? Is the combination oral drugs along with the MNT. That means with metformin you will add one more drug, maybe a sulfonylurea, maybe SGLT2 inhibitor, maybe DPP4 inhibitor, depending your choice of understanding of what this person needs. So, if HbA1c is 9 to 10, then probably one molecule will not work. So, combination along with MNT will be required, and if it is 300 or more than 300 and HbA1c is more than 10%, then probably you are a wiser person if you start using insulin from the beginning, because you are going to preserve beta cells for long run, and that is the day of but many times persons say कि नहीं डॉक्टर साहब इंसुलिन तो लगानी ही नहीं है, then you have no choice but you have to use oral hypoglycemic in that situation. And this is the line diagram of the same, how you go ahead, MNT, metformin, subsequently combination of different drugs. Now, coming to the last slide, again we must remember fasting glucose you have to achieve is 80 to 130, postprandial less than 180, HbA1c 7 and blood pressure 140 upon 80. So, you have to consider hypoglycemia always in your mind whenever you are dealing with oral hypoglycemic agent. Please come for the attendance. कोई भी एक जन आ जाइए. यहाँ डेट डाल दीजिए आज के, और नहीं ये तो कल का है शायद, इसके बाद यहाँ डालिए. 4th है आज क्लास ना आपकी, हाँ इधर ही डलेगा, आज 4th क्लास है, इसको निकाल देना.